Chapter 33, Diabetes and Metabolic Syndrome. So just a review of physiology here. Insulin and glucagon are the main controls of the body's energy system. These are the important parts about how the hormones function for nutrient metabolism and storage. Glucose, or carbs, is used for energy and fuel for the brain and the nervous system and red blood cells exclusively. The brain and nervous system needs a continuous supply, and whatever is not being used is stored as glycogen or turned to fat in the liver to maintain blood glucose levels. Glyconeogenesis is fat metabolism that turns fat into glucose. This can be done for all cells except the brain and nervous system. The end result of fat metabolism, or glyconeogenesis, is ketone production, which is an acidic byproduct. And when there's too much ketone production in diabetes, or like when you're fasting or on a high protein diet, it can be dysfunctional and create ketoacidosis. The important part here is that insulin is the only hormone that will reduce blood glucose. It reduces blood glucose levels by promoting glucose uptake by target cells. It provides glucose storage as glycogen. It prevents fat and glycogen breakdown. It inhibits gluconeogenesis, and it increases protein synthesis. And lastly, it promotes fat storage by transporting glucose into the fat. This is a high-level overview of what the pancreas does. The pancreas has two functions. The exocrine pancreas major function is to digest foods, and the endocrine pancreas major function is to release other hormones into the blood. Diabetes is a disease of the endocrine pancreas. So, high-level overview of what the endocrine pancreas does. We're going to be mainly concerned with the alpha and beta cells in the disease process of diabetes. The end resulting hormones are the ones that you see on that bottom row. Glucagon causes cells to release stored food into the blood. Insulin allows the cells in the body to take up glucose from the blood. Amylin slows glucose absorption in the small intestine and suppresses glucagon secretion. And somatostatin decreases gastrointestinal activity and also suppresses glucagon. Insulin, or blood glucose, functions in a negative feedback loop. When there are high levels of glucagon, activation in the adipose levels, fatty acid metabolism occurs for energy use. Glucagon increases during high levels of exercise to prevent a decrease in. There are two types of diabetes mellitus. Type 1, or insulin-dependent diabetes, is where the beta cells in the pancreas have been destroyed, majorly because of an autoimmune type process, so the body cannot produce insulin. Type 2 or non-insulin dependent diabetes is a combination of beta cell dysfunction and insulin resistance. So the body still makes insulin, but not as properly as it did in the past. And then the body also has a resistance to insulin. So the insulin that does get released doesn't get utilized the way that it's supposed to. There are some other types of diabetes that we're not going to worry about that have to do with genetic defects in either the action of the insulin or the production of insulin. And there are some drug interactions that can cause diabetes. So know that sometimes when we're helping in one area, for example, in the mental health medications that we administer, while it improves the secretion of hormones to help with the mental illness, it creates a situation where non-insulin dependent diabetes takes place. Another type of diabetes is the type that occurs during pregnancy, where we won't cover this in this class, but you will when you get to women's health. High-level overview concept map of diabetes type 2. Metabolic syndrome, or pre-diabetic, or pre-diabetes, as a lot of doctors like to say to their patients, is a situation where there is abdominal obesity, increased blood triglyceride levels, decreased HDL levels, high blood pressure, and an increased fasting glucose level. Metabolic syndrome creates insulin resistance and can contribute to the macrovascular disease processes of coronary artery disease, CVA, peripheral vascular disease. The major signs and symptoms that we see are intra-abdominal obesity and an overall systemic inflammation process throughout the body. We test that inflammation process through the ESR and another lab test called C-reactive protein. C-reactive protein as a test specifically indicates the inflammation reaction in blood vessels related to hyperlipidemia and abnormal fibrinolysis. In metabolic syndrome, you would expect that the C-reactive protein test would come back very high. Another high-level overview of how this occurs in the body. This also shows how our oral medications target the process. You don't have to memorize this, but it's just a really good visual of where the medicines work. Probably better for pharm than for this class, but for you, you need to know what are the target organs that are impacted by metabolic syndrome, and whether there's minor or major effects in those organs. Complications of diabetes. Diabetic ketoacidosis and hypoglycemia are the two most commonly seen. The Samoji effect and the dawn phenomenon, we're not going to focus on at all, so I'm not even going to talk about them. For this class, diabetic ketoacidosis, all you would need to know is this would be a serious complication of diabetes that would land somebody into the ICU, and we would need to intervene in a rapid way to get rid of the ketoacidosis. Hypoglycemia is probably the most common side effect or complication of diabetes, and you should be able to recognize and know the signs and symptoms of hypoglycemia. In DKA, these are all the things that take place. You would have the typical polyuria, polydipsia signs and symptoms, nausea and vomiting. This is where you get the fruity breath because of the ketosis that's going on. If this were allowed to advance, this person would end up in the intensive care with small respirations where the rate and depth of breathing is increased, tachycardia, and severe hyperglycemia over 250 milliliters. Generally, it's way over than that. Generally, it's 300 to 400 milligrams per deciliter. This is a emergency situation. We generally treat DKA by administering IV fluids rapidly, and those IV fluids will contain insulin, and we need to manage the electrolyte imbalances carefully between the sodium and potassium. If we decrease the blood sugar too rapidly, it can result in cerebral edema because of the sudden changes in osmolality. So this is a process that is managed one-to-one in the ICU. Hypoglycemia usually has a very rapid onset and progression based on a low blood glucose. It starts out with some fogginess or difficulty concentrating, and maybe a headache. Secondary signs, cool, clammy skin with sweating, diaphoresis. Last but not least, we go into a coma where the neuro system shuts down. This is usually diagnosed with blood glucose levels less than 60 milligrams, and we usually fix this by administering 15 to 20 grams or up to 50 grams of glucose, followed by complex carbohydrates to sustain levels. Every hospital has a hypoglycemia protocol, and nurses are trained in that protocol to be able to manage this using a standardized procedure. The most important part of diabetes that you will be studying this semester and next semester has to do with the chronic changes of diabetes. There are microvascular and macrovascular changes that occur. The target organs are the eyes, the nerves, the kidneys, and the coronary system. With microvascular changes, we see retinopathy, nephropathy, and neuropathy. Nephropathy is where the nephrons hypertrophy and create a situation where there's hyperfiltration. There's an excessive resorption of glucose that creates bigger pathways in the nephrons, which allows urinary albumin to be secreted into the urine. That's one of the first signs of diabetes, is having protein in your urine. The macrovascular changes we've already talked about when we looked at coronary artery disease. Diabetes aggravates atherosclerotic coronary artery disease. It also contributes to cerebrovascular disease, and it inhibits the ability of the body to productively heal itself and makes the individual more prone. One of the tests that we do for diabetes that allows us to understand whether the individual has taken good care of their glucose, managing their glucose levels, is the hemoglobin A1C. We can do this test and tell how well the individual has managed their glucose control over a period of the past 3 months, which has been very helpful in our ability to help patients manage their chronic disease. A great body visual for those of you that are visual to indicate what goes on and what kinds of signs and symptoms are seen when the diabetes has created difficulties in the other organ systems. So, for example, if we were looking at the cardiovascular system, you would see hypertension, you would see atherosclerosis and ischemic heart disease, and peripheral vascular disease, leading to opportunities for gangrene and infection. The other body systems are also noted on this slide. This is something that you should begin to memorize. These are the reasons people are in and out of the hospital because of diabetes. They're not coming in to control their diabetes. They're coming in because they have one of these other systems or multi-body systems involved. Diabetic neuropathy or nerve pain is a burning pain that occurs in the extremities. It's also a diminished perception of pain and temperature. This is what makes the people with diabetes more at risk. They also have autonomic neuropathy that takes place as a result of this, which creates defects in the vasomotor and cardiac responses of the body. It impairs the motility of the GI tract, and it creates problems in the GI-GU system where there's a decreased bladder stimulation, allowing emptying of the bladder, and in males it represents sexual dysfunction in the form of inability to maintain an erection. This neuropathy occurs because of the osmolality in the blood. When it's high, because there's glucose floating around in the blood, it causes the cells to shrink, and the nerve cells produce an intracellular substance to be able to keep their osmolality balanced in order to work. And when the client brings the blood glucose back down to normal, the nerve cells become hyperosmolar to the blood, and they end up sucking in water and swelling, and that swelling creates the nerve damage and the demyelinization that occurs in the neurosystem.